It's still good morning and welcome all. It's a fun Adalat, not a serious Adalat. I'm not going to kill anyone. So that's why white. I'm not in a color of death, black. I will like to invite our judges. May I start with Dr. Subhash Kaul is getting his picture. So, Mark, maybe you can join us. So, Dr. Mark Rebo, Dr. Mukesh Sharma, he is hiding behind his laptop there. Dr. Puneet. So Dr. Puneet and Dr. Mukesh will be judged as well as they are the judge. So it's a contradict. And Dr. Subhash Kaul, sir, if you can join us on the dais here.
Hi, how are you?
Rishu.
Sir, आप just just yeah, the connect.
So they will put up the slide, right? Puneet will put up the slide.
Judge एक ही है कि दो judges?
So maybe Dr. Mark, can you join Dr. Subhash here? Because they both are petitioner also. So you are given a higher position here with him. So the design is simple. You all are also judge of what they're going to present and do. And I invite Dr. Puneet Agarwal here first. And Dr. Puneet is Director of Neurology in Max Saket, Delhi. And he's a leading neurophysician with more than 2 decades of experience behind him. And I'm sure he will have an exciting case for us to see. Over to you.
So thanks, Dr. Arun, Dr. Gaurav, for organizing a very fascinating session. Without wasting time, I'll start my case. So it's an interesting case which came to me. He's a doctor by profession from UK. He came to me. He's a 36-year male, and he came to me recently with a sudden onset tingling and numbness in the right upper limb, the right side of the face, with weakness on the right upper limb 7 days back. Patient had similar 3 episodes between April to May 24 in UK. He was working there, and he was admitted in NHS hospital in UK, where he was diagnosed as acute ischemic stroke involving the left MCA territory. Stroke work was done there, and APLA was found to be positive there, IG and IgM. Mild it, but no IgG was negative at the time. Lupus anticoagulant was negative. So he started with the anticoagulation. Despite anticoagulation, he developed third attack there, and then he came to India for the just for the second opinion and for the further workup. So on examination, patient had a recent stroke. That is a fourth one here, 7 days back. The vitals were stable. The pulse rate was regular. He's a 36-year guy. The mild dysarthria, power was right 4/5 on the right upper limb. Mild numbness, dysesthesia was there in the right upper limb only. Plantar flexor, no cerebral signs. And this is the MRI showing, you can see diffusion. It's a subacute infarct showing the centrum semi-ovale on the left side, and not matching the ADC. It was a subacute infarct. And in the flare, you can see the high impedance signal in the MCA territory on the left side, in the frontoparietal area and the high frontal area, it's mainly in the left MC area. So he was further workup here. He was admitted here. The T was done, which are showing PFO, and which is showing mild right to left shunt, but it was a small PFO according to the cardiologist. The APLA here was done 2 times, which was showing IgM and the IgG. So IgM was here was negative, and IgG was also negative, but beta 2 GP1 IgA was positive here, which was done 2 times and mildly positive. The earlier the APLA was done in UK about 4 weeks back. The lupus anticoagulant was negative. Patient was having around mild homocystinemia, MTHFR gene mutation. So I'm just showing the positive findings. Heterozygous mutation was found, not homozygous. The vasculitis workup, ANA-C, the ANA vasculitis profile was negative, AC level normal. The protein CS, lupus anticoagulants, ESR, CRP, and C3, C4 all were normal. Patient CSF was done, showing a mild raised protein, 65 mg/%. Rest is normal. CSF ACE level was also done, which is normal. and patient was genetic sequencing. After discussing the whole exome sequencing was sent, which was later on came out. The report came later on. It was normal. There was no different. There were no significant mutation found. The DADA2 mutation was negative. We did the DSA also in this patient. If you see here, this is showing the DSA is showing left ICA terminal portion. There is a severe narrowing, and there is a severe narrowing of the M1 segment of the MCA also, and the ACA was also showing. So left ACA was showing non-opacification, and the left AMCA is basically filled from the PC of the left side. Other arteries were normal. So right side ICA, right MCA, vertebrals were normal. So these are DSA you can see here. So we did the MRI vessel wall imaging also, suspecting to know the exact etiology of the disease, and showing there is you can see here there is an inflammation. There is a definitive contrast enhancement in the left ICA, and left MCA segment was there on the left side, and there is a definitive contrast enhancement you can see very well. So the patient was basically, the final diagnosis we made was a recurrent ischemic stroke, 4 episodes in the same territory, in the left MCA territory, with left terminal IC and MC involvement, M1 stenosis, and with the marked vessel contrast enhancement, raised CSF protein. We've kept the possibility of primary CNS vasculitis, despite having APLA was positive there, but we found that APLA was not very much significant here in our workup with PFO, but again, which is not matching with the clinical picture. So we stopped the anticoagulation and antiplatelet was started. We label as a CNS vasculitis, patient was managed with the methylprednisolone, and after discussion, he does not opt for the cyclophosphamide to be started, so we opted for the rituximab. 2 doses were given. So I stop it according to the seminar topic that did I do a correct thing in the management or not. So just show you the follow-up. Patient is 1 month follow-up to me till now, which is showing there is no, because in last 2 months patient had a 3 episodes of stroke, 2.5 months 4 episodes, but in last 1 month there is no stroke now, and patient is clinical symptoms have recovered. Plan to do the DSA MRI vessel wall imaging after 8 weeks. Thank you. So they are just references. I think we can discuss later on.
So to sum up, this is a patient of recurrent stroke in the same territory, and initial diagnosis was antiphospholipid antibody.
Yeah, that was
in UK.
Outside. Yeah, in UK.
So since the antibodies were positive at the time, then why do you think it is not? And what are your arguments against that?
So my take was initially also I opted for because the first is the odd point to me with the APLA syndrome is there is no history of venous thrombosis. Patient was having a stenosis, which is a very rare thing with the APLA syndrome. Usually the patient's having a thrombus or venous thrombus common with the APLA syndrome. Second is for the diagnosis of APLA syndrome, we should have a persistent raised APLA antibodies at 12 weeks interval. So that's why we opted for the APLA here also, which was negative in our setup, so which is very common. So APLA antibody can be transient, can transiently found in many cases due to the associated autoimmune reaction. It is very well known. It has been found in giant cell arteritis and various other kind of vasculitis also. So that's why we opted for, and our vessel wall imaging is showing clear-cut contrast enhancement on the left side.
Yeah. So I agree with you. For the diagnosis of APLA, we need to have full house. It should not be that IgA is positive, IgM is negative, lupus is negative. We need to have full house, and there has to be repeated after 12 weeks, it has to say. So I think I agree with you in not considering APLA. This is one. The second etiology was found on TEE as patent foramen ovale.
Yeah.
So why do you think that is not the culprit?
So that was an interesting finding. We found it. PFO. The only odd point which we found is we have done the venous Doppler. There was no DVT at all. So to having a PFO, having a similar type of stroke, stereotype of stroke confining to the one territory is a very rare thing again. A PFO is leading to usually can lead to a multiple stroke, multiple infarcts in various territory if it is an embolic one from the heart. Second is I'm not finding any source of emboli going from the leg of somewhere else, by which we can say that PFO is a culprit. That's why we did the genetic study also, data to find out data to mutation, in which we have certain many time young stroke, stenosis with the hematological abnormalities, and the sometimes the cardiac abnormalities, which was negative. So I was not convinced with the PFO as a etiology for the stroke in this case.
Yeah. But it was a very
Yeah.
significant PFO in the sense
Yeah,
that you
yeah,
demonstrated a
yeah,
shunt.
yes, sir.
But then again, to have in the same territory every time would also be difficult to accept. Now, my most important question, which is relevant to this case, is that you think it is a secondary moya moya, which means that
Yeah.
it is a moya moya like picture. There's a
Yeah.
terminal ICA, but then there is a you think it is secondary to vasculitis.
Yes.
Now, that is what I want you to justify. Uh, because even in vasculitis, do you have evidence of vasculitis in other
Yeah.
territories in this patient?
Yes, sir, you're right. So we kept as a Moya Moya syndrome in this case, or secondary Moya Moya, and because it is a localized kind of finding which we found right now, which is again atypical of CNS vasculitis. But I think this may be a evolution stage of the patient. He is a young age, hardly 2.5 months history, and if we don't treat it right now, after 6 months, he can come up with a full-blown vasculitis feature. So I think that can, so this is a atypical finding with CNS vasculitis, but this is what we find in the case.
Yeah, there is no doubt that it is vasculitis, no doubt about it. But what is interesting, and all of us are seeing this in our practice, that it is very focal. It's only restricted to one vessel, and many of these patients in our practice we are seeing they are having underlying hypertension and diabetes. Your patient did not have.
Not happen. He's a young age guy, perfectly healthy person.
Yeah. So this is some kind of this is not a classical primary cerebral angiitis as we know it, because that would be in various territories and
Right,
all.
sir.
But I think given the situation and the recurrence and all, I would agree with your decision of putting him on immunosuppressive. But it has to be kept under follow-up to know
Yeah.
whether it evolves into
So we are
something
doing
else.
after 8 weeks, we are doing a repeat DSA and vessel wall imaging again to see that.
But vessel wall imaging is characteristic of vasculitis because it's quite concentric.
Yeah.
But the only odd thing for a vasculitis is restricted to one vessel.
Yes,
That's
definitely. This is a very, so this is an odd point with this case. So I'm sending for the publication. This is definitely one of the interesting finding in this case, very localized feature of CNS vasculitis. Yeah.
So my learning point here is, if you describe it as it happened, you after the first admission, you did not discover this stenotic lesion. Then you discovered the PFO, and at the end you found out that there's a stenotic lesion with vasculitis. So my learning point here is that for some reason at the first admission it was not done, but at one point I was about to indicate closure of the PFO, and this could have happened if you didn't, and this patient could have closed his PFO, have unnecessarily having this lesion here. So the importance of going step by step, and from the first time you have symptoms, trying to find out if there's any stenosis or occlusion in the affected segments.
Yeah, definitely. And I think you are right that with the finding of PFO, I have to be vigilant in the future also, because that can contribute to the further stroke also. So because this right to left shunt was there in this case. So we'll keep the patient under observation. We'll keep on monitoring him.
They had not done this vascular imaging when she was in UK in the
Yeah, that vascular imaging was not done there. They've done the DSA. They found there was a stenosis there, but they found the APLA positive, IgM, and this one IgA was positive there. So that's why they've started.
So one last comment. I think we also do vessel wall imaging, but not for all ICATs. So because if you just look at the angiographic picture, your first impression is it's a severe ICAT sort of a picture. So do you do vessel wall imaging in all your patients, or you
No.
decided to do only for him?
Yeah, so I don't do, in practice, I don't do the vessel movement very commonly, but in this case, because it's a young stroke with having a recurrent stroke in the same territory with a stenosis, and we are not able to find out the reason. That's why I go for and CSF was showing mild raised protein at the time, so that's why I went for the vessel wall imaging.
In etiology wise, like herpes, varicella zoster vasculopathy, also involve this area, supraclinical ICA. So I have 3 patients where the IgM or IgG for a zoster was significantly high. We treated with the 1 month of acyclovir and steroid, and all 3 patients responded. So I think varicella zoster antibodies should be done in these kind of the patient where the vessel wall imaging showing the concentric contrast enhancement in a MRI.
Yeah, yeah. In APLA case, definitely the antibody should be repeated at least after 12 weeks. It should be repeated again. In APLA, if you're
Not
finding the
APLA,
IgM, IgG positive.
varicella zoster.
Oh, varicella zoster. Okay, okay.
I know, Mukesh, what you are trying to do. You want him to be killed so you can be spared. So that's your strategy.
And varicella zoster is one of the inciting trigger also of CNS vasculitis many times.
Yes.
Yeah, it has been reported. Yeah.
No, I agree with you that we should routinely do varicella, particularly because we have to explain this, why this one vessel is involved. Now, technically we can say this is a focal cerebral arteriopathy. Focal word is very important. Usually that is found in children. But if in an adult we find this enhancing active thing, one of the causes to be ruled out is varicella. And sometimes there is literature where varicella can trigger the primary cerebral angioids also. It can be a trigger and eventually patient may get full-fledged
But in
vasculitis.
CSF, we have done the varicella zoster PCR in CSF.
That was negative?
That was negative.
No, it's
So
actually
in
the
CSF, we have done
antibodies.
the everything. We have done
Yeah, it's
everything.
more
So that
of
rules it out.
That was negative.
They have done varicella in the CSF.
In
it has been
CSF, the
ruled.
biofire was done. That was negative for
Yeah, that
varicella
is the
zoster.
test to be
Usually
done.
Yeah.
is a sequelae of after infection probably, sir. So it's a, I don't know. So
No, but it
recommendation is the CSF antibodies.
Yeah, they have done that. You have done CSF
No,
antibodies.
they have done the PCR.
So we have done CSF PCR for varicella zoster.
That is enough.
That's
enough.
that's negative. That
enough.
was negative.
So what's the verdict for him? Can we let him go? Okay.
I would let him go. I would do just the same. Thank you.
Thank you. Thank you.
So now we invite next petitioner, Dr. Mukesh Sharma. So Mukesh has 2 heads. So he is head of director of neurointervention as well as stroke unit at CIMS Hospital, Marengo CIMS at Ahmedabad. And I'm sure he is going to have that mixed sort of presentation of both neurology and intervention.
He's basically.
It should come, no, directly. Okay. Hello, everyone. First of all, I would like to thank Dr. Arun Garg and Dr. Gaurav for this opportunity. It's a very short case. A young lady who is post MVR status on mechanical wall. She was on the acetylene, and because of the trauma, she needed a knee surgery. So she was put on the low molecular weight heparin from the acetylene, and day second, she developed the stroke. So as usual in our hospital, we activate whenever there is a stroke suspect in our hospital. So stroke code was activated. I got the phone call early in the morning. So she was having the aphasia and right side hemiplegia. And so immediately patient was shifted to the CT scan. And after the CT scan, my fellow saw her, and that time NHS score from 20 to reach to the 10. So we discussed with the relative, better to do the DSA. So we shifted that lady to do the DSA. When I have examined after 1 hour, her NHS score was 4. She was just having some motor aphasia and little bit of grip weakness. This is the CT scan. You can see the first MCA dot sign, MCA code sign. Otherwise, CT is perfectly normal. And you can see MCA is occluded from the M1 segment. This is the angiogram, lateral view, and this is AP view or Towns view. So we left with these options. My case is open. What should we do the next?
So one thing I need to understand, why did you wait for an hour? Like the NHS was 20, then it dropped
No,
to
we have
4.
not wait for hours in the early morning hours. So shifted the patient to the CT scan, then preparing the patient for the DSA. So it took around 1 hour.
So why not do a CT and CT angiogram and demonstrate the
I can
occlusion?
see that the hyperdense MC sign. Why we want to do that further? There is already cardiac patient.
So when you are doing an
post-surgery.
angio, you are doing it with an intent to treat.
Yeah, because the NHS score even post CT scan was 10. So we went for to treat this patient.
You said 4.
No, 4 when I have examined on the table before doing the DSA. Post CT it was 10. Then when I have examined, so after 30 minutes around 10 and 1 hour it was 4.
So she was recovering.
She was recovering.
So when you saw at that time, what was your imaging? What was the data which you had based on the data available to you? At a time when it was NIHS 4, what was the finding on the angiogram?
So angiogram, this is that collaterals. Again, I'm going to show you the DSA. So if you observe this DSA, that pile collateral from ACA filling the MCA, and in the lateral view, if you see, these are the intermediate collaterals. These are not a good collaterals to probably sustain. It's not a good collateral because the collaterals are coming in the late or in the venous phase actually.
No, so
probably this is the autoregulation and the collateral working on the peak in this lady, whatever we are having the imaging and the angiography.
So, I mean, you can ask this question before you do the groin puncture. I think it's reasonable not to treat. There is no strong evidence that thrombectomy works. In fact, there are 2 or 3 clinical trials that are including exactly these kind of patients because we don't know the answer. Now, once you have done the groin puncture and you have your catheter here, and also knowing that the patient at some point had an NIH of 20 previously. If she never had an NIH of 20, you could think that the robust collaterals will take over. But it's evident that the collaterals are not so robust and she can fluctuate. Also, you had to know that she lives on the collaterals, but when you're going to do your procedure, you are going to occupy space in this internal carotid artery with your...
So this angio is done from the common carotid, not from the ICA.
But when you're going to do the thrombectomy, you're going to stick or push a big catheter in the ICA that will take space. You're going to probably kill the collaterals. No, I'm only saying because you need to minimize the time you have your catheter or your big catheters in the carotid when you're doing this kind of patients. But at this point, I would do the thrombectomy.
So you want to go for the thrombectomy?
Ramkesh, when was the last LMWH given to the patient?
Pardon?
When was the last, Dr. Mukesh?
Yeah.
So you written that the patient was on low molecular heparin. When was the last LMWH given to the patient?
Before surgery. Before surgery.
Before surgery means
day
how many
before
hours?
surgery. Day before surgery.
Means 24 hours before.
Yeah, more than 24 hours. Yeah.
So, no, you have to show what you did.
Okay. So definitely.
He's asking what we would have done. He's,
So this patient here is having the alveo with mild neurological deficit. So C is not a candidate for the IV thrombolysis. For is this situation, the best medical treatment is the IV thrombolysis, which cannot offer in this patient, number one. Stroke onset, NHS score was quite high, significantly high. So these patients who presented with the very high NHS score and they improve, they have very high chances. If autoregulation fails, they deteriorate very fast. Number two. And procedure risk, because I know that thrombus size on a CT is very small. It's 1 or 2 passes I will able to remove this. And in our center, we are doing around 6 to 10 thrombectomy per month for last 10 years now. And again, the secondary prophylaxis we cannot offer because the surgery is done day before. So we offer the treatment in one pass. Artery is opened up, and this is the post-procedure CT scan. So how to actually treat these patients? A very nice paper. So around 23% of the patients, they deteriorate in next 24 hours. Around 33.3% patients, they deteriorate in that hospital stay. Around 42% in the next 3 months. Okay. So how to evaluate these patients? So you can do the stress test. Stress test means you allow the patient to sit or stand. If NHS score is going down, take the patient. These patients are likely to deteriorate. The second, you do the CT perfusion. If a hypoperfusion area is more than 70 ml, better to do the endovascular treatment because rescue endovascular treatment have the bad prognosis compared to the best medical treatment or early endovascular treatment. So we have to find out which patient is likely to deteriorate in low NHS score with LVO. Another patient, similar patient, sensory aphasia, young lady presented to us. MRI I am not having. This lady was having the small infarction involving the axonal capsule and posterior part of insula. So we did the CT perfusion in this case, and you can see the large area of hypoperfusion area, and we offer in this patient thrombectomy. So whenever we are analyzing, we are treating a low NHS score patient, we have to differentiate. Is a disabled stroke or non-disabled stroke, like in the IV thrombolysis. The similar way we should for the LVO also. So those who are presenting with left side hemiparesis or lower limb weakness, they will be less disabled in comparison to aphasia, sensory motor or hemianopia, and right side upper limb weakness. So these kind of the patients should be treated with endovascular treatment. There is a nice paper published recently and published in the Stroke Journal 2024. There's clear-cut flow chart. Patient with a LVO with a low NHS score having disabled stroke. If CT is okay, good, aspect is good, like 9 or 10, then go for the CT perfusion. If there is a hypoperfusion area more than 70 ml, ask for the endovascular treatment. If it is less, wait. If they deteriorate, go for the endovascular treatment. So like in this case, we did thrombectomy. So mild stroke, usually around 25 to 35% have the poor outcome. And around 15 to 30% of the patient, they have early deterioration. So we have to find out these early deteriorate, those who are likely to deteriorate in next 24 hours, and by doing the stress test, by doing the CT perfusion, and better to offer. So we don't have the clear answer. The two trials are going on right now. One is the Mosley, or one is the Endolo. Probably will answer for the low INH score with LVO. Thank you so much.
So I don't know if I have done the same. So because like we all low NHS and large vessel occlusion is a gray zone, as you said. Like we do not have clear-cut evidence, and typically, as Mark also said, like that decision should have been done before you puncture and you did an angiogram. So if the patient is having an improving stroke, like rather it's not a low NHS, but it's a rapidly improving stroke, it's good that we could go in and we can grab the clots out, but I also remember those patients where we went in and we made it worse because we created a shower of emboli and we shut down the collaterals. So if even one out of those 5 patients they did bad, it's probably not beneficial. I do not know. So for me, it's still a gray zone where we debate, discuss, and we do all those stress tests and perfusion to make a decision. So I'm still doubtful if I would have done the same. So
That's
I
why
don't know.
in the second case, I shown you that we did the CT perfusion first. There was a huge area of hypoperfusion, and then we offered the thrombectomy. Yeah, in each first case, when we took her, NHS score was 10. But yeah, only those who were in the cath lab knowing the patient has improved. For the relative side, patient was having the aphasia and right side weakness.
Dr. Mukesh, I think very well presented. This is a really a bugbear situation. I mean, particularly when it's a low NIHS patient has a mild stroke, particularly sometimes it's a non-disabling stroke, and you have a large vessel occlusion, and it is a ticking bomb. Anytime it can blast.
Yeah,
And-
non-disable, I think endovascular should not be offered.
And exactly. And when such a thing happens, there's a possibility it can progress also, and there's a possibility it may not. So that is why it is what I said, it's a very difficult situation what to do. So, and sometimes it becomes for a neurologist because they ask us what should we do and all. So I have interviewed many interventionalists all over the country. I think Gaurav also interviewed, and Vikram who did and all. And most of them say, because they go by guidelines. Sometimes when we don't know what to do, we clutch the guidelines for our own protection. And guidelines as of today say that if you have got a low NIHS, then hold on, then don't disturb the patient. But we know that sometimes the patients can suffer. And I think in your case, I would support your decision because of 2 reasons. One is that you have shown that there is that large area of perfusion. That means that's a brain at risk. It's not brain at risk. Second is what my co-chairperson said, that he had a preceding NIHS of 20, which means that much of is under threat. And it is very unstable situation. So I think based on those 2 criteria, I would probably endorse what you did. And then nothing succeeds like success. Your outcome was very good.
I agree with what was said here. The only thing, I'm not sure we have sufficient knowledge to interpret CTP maps to make a decision. Yeah, there might be delays in areas that will not lead to definitive lesions. So having a delay in the CTP maps might not necessarily indicate that, or we don't have enough knowledge to interpret that. Maybe it will remain delayed but compensated. So I wouldn't take the decision based on the CTP maps.
So what
In interest
how
of
you
time,
how
we
you
need to decide guilty, not guilty.
I would say not guilty.
now,
I would
how
let
you
him
decide
go.
them? How you decide patient with the LVO having a low NHS score? How you treat those?
No, time is over. We just need to have a verdict: guilty, not guilty.
Give them the benefit of doubt, not guilty.
Okay, so not Baizat, bari, but not Baizat. Thank you, Mukesh. Thank you so much.
Not
Thank you
guilty.
so much.
Not guilty. We are letting you go.
Thank you.
Okay. I'm sorry, it's an interesting debate, but we have to move on. Time is of an essence. So I called our last petitioner, Dr. Treman Singh Sikand. 2 minutes will do it. Time is there? Okay. So the organizers are requesting we have to close down this Adalat, and I wanted to see all 3 of them getting released, but we had 2 which were released, so it's fair enough. So thank you so much. Nice cases. Thank you, judges, for being here, and we close this session. Thank you a lot. Thank you so much. Thank you.